Hi everyone, welcome to the first part of our diabetes review of 2022. In this video series, we'll be highlighting some of the key areas that we feel will impact the management of diabetes in clinical practice. 2022 was yet another action-packed year for diabetes, full of new medications, new licenses, but also guideline updates. And that's what we're going to be focusing on in this first video. So guideline updates, really, there's a lot there that has obviously clinical implication. And to help summarize all of those guidelines and to put it into clinical context, we've got our dream team of Dr Sarah Davies, Amar Puttanna and Patrick Holmes. Welcome everyone. Now, we're going to be looking at four particular updates. So first of all, the NICE guidance and its type 2 diabetes update. Then we're going to move on to the ADA EASD consensus statement, looking at their updates on type 2 diabetes management. Then looking at NICE's recommendations on glucose monitoring, the updates there. And finally, we're going to round it off with the update from KDIGO, the International Kidney Group, who've given some updates on CKD and type 2 diabetes. So in each of those, we're going to be asking three main questions really. What's new? Why is that important? And what are the implications to clinical practice? So without further ado, we're going to hand over to Patrick to start things off with the NICE guideline update for type 2 diabetes. Over to you, Patrick.
So NG28, that's the new type 2 diabetes guidelines. So it's been out a few months now. So hopefully a lot of you will have already seen it and maybe started to make some thinking behind it. An important part of this is NICE have specifically looked at all the cardiovascular outcome trials and actually increasingly been also looking at some of the renal outcome trials as well. And their conclusion is essentially SGLT2 inhibitors have a very prominent role. Remember NICE has these two, you either have offer, which is their strongest recommendation, and then there's a lesser recommendation of consider. But they are talking about dual initiation. So really not quite at the beginning, you're going to give SGLT2 inhibitors, but they're talking about you start metformin in certain groups of people, and as soon as you establish they're tolerated, before you've done a HbA1c or additional checks, you are then starting to initiate the SGLT2 inhibitors. So it's not incrementally adding. And they're particularly saying we should be offering it to people who are living with type 2 diabetes if they've also got heart failure with reduced ejection fraction. So that's the strongest recommendation. Also, if they've got heavy albuminuria and above 30 milligrams per mole, ACR, we should be offering that to people with type 2 diabetes. Again, that's the strongest recommendation. And then there's there's a lower recommendation, which is the consider, but that's still a fairly strong recommendation. And that's saying that everybody over the age of 40 with a Q risk above 10% should be on an SGLT2 inhibitor at initiation. That, in my area, is basically everybody over the age of 40. So that's a huge change. And I'm not seeing many people actually following that through. We're still used to adding one and then adding on another. And so, you know, these are big changes. These are enormous. I mean, I'm involved in the region of the Northeast and North Cumbria. We have some localities in these regions who traditionally have not prescribed SGLT2 inhibitors. So this is hugely challenging in terms of how do we counsel people for this. I've been asked, in fact, to go to North Cumbria to speak to their GPs specifically about this issue. So I can understand there are significant concerns. So I think we have actually covered some of these topics before. So I would refer those to previous conversations, but it's a huge change. I mean, I suppose, and why that change? As I say, it's been driven by the outcomes from the cardiovascular outcome trials. Remember, you know, the majority of people living with type 2 diabetes during their diabetes journey will experience either CKD or cardiac issues such as heart failure or myocardial infarction. So, the purpose of this is to try to keep people at home and out of hospital, yeah, so it's I think it's, for me, it's what I've been doing for a long period of time, I think, but I was surprised at that Q risk of 10. So because I think that's as it said, that's such a large number of people. I don't know, that to me is the biggest implication to practice. I know the way I'm implementing it is I'm proactively looking at these higher risk groups and the lowest groups, because it's so many people. We are just, when we're doing regular reviews, but it has to be said, there are some of my colleagues are still struggling with this in practice. I don't know what your experience, Sarah, I don't know what your experience is in Wales, if it's similar to what I'm finding in the northeast of England.
Yeah, no, thanks, Patrick. And I think you're right. I think it's a big, brave decision, this kind of widespread use from the start of a diagnosis of type 2 diabetes for the majority of our patients. And for me, it's a mindset change. So it's getting over the fact that you're adding medications incrementally just to get that HbA1c down. And actually now you're thinking of using the SGLT2 inhibitor as per the NICE guidance for its cardiovascular renal protection and not necessarily for glycemic control. So I've started making the analogy when I'm teaching about this guidance to statins and having the conversation that we're familiar with having about statin therapy, but with SGLT2. So actually we're thinking about starting this medication. Now you're on your metformin, brilliant. Now let's get that one in that we talked about, which is going to protect your heart and kidneys. And actually in our practice now, my practice nurses are well across this. And, you know, I'm sort of trying to spread the word and get this into good practice now. But I agree, it's a big, brave decision and definitely going to lead to some changes in practice.
So Sarah, I just wanted to ask you, how amenable are patients to this? Because they may come back with, well-controlled glucose levels and whatnot, and there's this discussion about risk and having a preventative medication coming in, which, as with all medicines, may have certain side effects. So how amenable are patients? How does that discussion go in your experience?
So it's just like the primary prevention statin conversation. Some people are really pro it and some just are not bothered. But interestingly, I would say since the guidance came out, middle of last year, most of our patients have gone for that. Especially when you talk about protecting your heart and your kidneys, actually people are worried, particularly perhaps more about their kidney health even than their cardiovascular health. Perhaps they can get their head around that a bit more. And actually many of our patients in our own practice anyway have gone ahead and gone for that early SGLT2 inhibitor use.
Brilliant. Amar, any thoughts from you on this?
Yeah, I just want picking up what Patrick said about that Q score of 10%. It's an interesting one, isn't it? Because I guess you have to have a line somewhere and quantify what does cardiovascular risk mean. You could say multiple risk factors, and then that means someone has to kind of look through all the risk factors, and you've got to assimilate it or use algorithms to figure it out. But then a simplification of that is a Q score of 10%, which we have for statins. So, and that's the reason we start statins as well, isn't it? So it kind of merges that, and it probably simplifies it to make it a bit easier for yourselves and ourselves in a way with regards to that. So that was my thoughts on that. I guess it's interesting when you compare. I mean, the reason why we wanted this update to the NICE guideline was because of the ADA-ESD consensus, wasn't it? The original one that put SGLT2s and GLP-1s front and center in cardiovascular risk reduction. And not to be outdone by NICE, the ADA-ESD came out with their updated consensus actually at the latter part of 2022. And this was interesting because, firstly, I would say NICE would probably take a leaf out of their book and have better illustrations or better imaging. I think there's some really nice diagrams and infographic kind of style things at the ADA-ESD guidelines on a number of things, which make it a lot easier to read, actually, I would say. Nothing against NICE, but it's just, when you view it, it makes you want to read it a little more. So that was one thing. But the other thing really with this guideline, so if we look at, there are two main aspects with this guideline, I would say, which would take homes for me and for most people. The first thing was really the importance of 24-hour physical behaviors for managing type 2 diabetes. And this is stuff they said for type 2 diabetes, but it could be for any of us really for healthy living. And it was the 5 S's, you might hear. So it was sitting. So, important to break up prolonged periods of sitting. So make sure you say every kind of 30 minutes or so you stand or so, have a little bouts of walking around just to kind of get get some mobility, get some exercise or so, some simple exercise to improve glucose metabolism. Stepping. And the good thing with all this is that they actually kind of give you definite figures. They didn't just say increase walking, increase exercise, increase this. It was more specific, which really helps all of us really in advising our patients. So stepping, so increase of about 500 steps a day is associated with just under 10%, about 9% reduction in cardiovascular morbidity and all-cause mortality. That's quite significant. 500 steps a day is not a huge amount, which is why they say break up sitting and then stepping, or kind of 5 to 6 minutes of brisk walking a day. Increases your life expectancy by 4 years or so. So again, these are really nice kind of details they give, which kind of highlights that. Sleeping, something that I need to do more. I'm sure we all need to do a little bit more of, or a lot more of. And they even advise on sleeping as well. So, between less than 6 hours or more than 8 hours is actually not good. So between 6 and 8 hours is ideal for HbA1c improvement, and, the quality of sleep as well. So it highlights a bit about that. Sweating, the importance of moderate to vigorous exercise, about 150 minutes a week or so of kind of moderate intensity, or about 75 minutes a week of quite significant intensity exercise, no more than 2 days of consecutive days of inactivity, basically keeping you active. And then also strengthening again, so resistance exercise, so that uses your own body weight or works against resistance, is also beneficial. So sitting, stepping, sleep, sweating, strengthening, the 5 S's of they say type 2 diabetes, I'd say all of us, that we probably should do. Whether we do it or not, whether we can do it, whether we have the time for it, that's another matter. But I think that's really important. And the fact that they've laid it out so clearly with, clear reasoning behind it, and something that we could take to our patients, I think that's probably the highlight for me of that whole guideline, more so than the medical side of things, the medication side, sorry. Before I go on to the next page, I want to get your thoughts on that. Does that help you at all, primary care? Is that something that we I guess from my side, not quite guilty, but you say, we should advise you to increase exercise more, and yes, 150 minutes a week, but we don't go into the specifics of why that's important, or even just steps.
Yeah, absolutely.
Your thoughts?
I think you touched on a point earlier on about the infographics. For me, ADA-ESD is all about the infographics. And with this 24-hour kind of lifestyle advice that they've given, again, really like beautifully presented infographics, something that you could share with a patient. And the beauty of it is that it's a 24-hour plan. It includes sleep as well, which I think is really critical. So, a really good sort of discussion aid, I think, with patients. And it may not be covered completely within one appointment, but at least it's something that someone can take home with them, or it can just be the start of a discussion. I don't know, Sarah, what your thoughts are, whether you've used it much or reflected on it at all.
Yeah, no, I echo what you've said, really. It's very pretty. My practice nurses have loved this infographic. And the important thing is it's individualized. So, it's not realistic for us to tell some of our patients to suddenly start going and doing 150 minutes of vigorous exercise a week. That's not realistic for someone who perhaps has been entirely sedentary up to now. But actually increasing your steps by 500 per day is potentially achievable for a lot of people, and they can actually see what the potential impact is that on their cardiometabolic health from this guidance. And I think that's very, very motivational. I'm a big fan of this.
And of course, this can be implemented straight away. This doesn't it doesn't need to go through a NICE lens. This is good to go now. This is not drugs and cost effectiveness. This is just communicating the advice we should have been communicating for a while in a nice, simple, straightforward way.
Exactly, and I'd say this is what we can use. Yeah, regardless of comparing different guidelines, this is something that's practical for anyone across the world, I would say. So yeah, you don't need to kind of say, oh, this guideline has it. It's not in the NICE guidelines, because this is practical information and support. So great, I agree. The other thing when you mention the ADHD guidelines, I guess, is also the medical therapy, the glucose lowering therapy in type 2 diabetes, and we saw it NICE with the changes to SGLT2s. Irrespective of kind of metformin, separate to that, it's about cardiovascular risk. The ADHD guidelines also agree with that and say, they say assess someone's cardiovascular risk. It's not about metformin then assess cardiovascular risk. That's separate. So again, they've also agreed with NICE and said, yeah, assess cardio-renal risk actually is what they say, because they've split it up into CKD, heart failure, high risk of cardiovascular disease, or high risk or established atherosclerotic cardiovascular disease. So these kind of groups, and all of them should benefit from SGLT2s, especially heart failure, CKD, but also ASCVD or high risk. But they've also, slightly different to NICE, and we can pick up on this, they've also recommended GLP-1 receptor agonists as well as an option in those with ASCVD or at high risk of ASCVD as well. But not just that, from the cardiovascular side, they've also focused on glycemic management and also weight management as well. And they've highlighted weight management, actually, which is probably looking to the future, looking at obesity crisis, as they call it, and everything else in between. They've looked at that specifically in this guideline, so they focus on that weight loss and the importance of achieving weight loss, and that 15% goal weight loss effectively, and looked at medical therapies that would achieve that. And they've gone in terms of efficacy, and they've looked a little bit to kind of what might be coming for us as well. So high strength incretins, the dual incretins. Then they've looked at obviously the next tier, which is the current incretins that we have, GLP-1s and SGLT2s, and then those don't do as well, like DPP-4. So they put it into kind of tiers and asked and highlighted the importance of that. Not forgetting, of course, weight loss, calorie restriction, and that side of things in the direct trial. So I think really they've again shifted what we wanted in the guideline and added to it and made us consider, actually, do we have to look a bit more at that? And the fact that weight was included in that main thing, I think, is very important moving forward. So again, we would have to look to say to NICE, actually, well, that's a nicer guideline in a way. Interested to hear your thoughts around the GLP-1 side of things. I think this has been a big talking point, and there's a recent article that came out actually in one of the journals about this actually in GLP-1. So I think it's interesting to hear from yourselves about that.
I was just going to say with that, I think what would be really helpful for our viewers is our take on, a bit of an assessment. So we've got NICE on one hand, giving their very SGLT2 centric guidance and remaining pretty much where they were with GLP-1 from their previous guidance, to now ADA ESD consensus statement, where really GLP-1s are at the forefront of management, and there's that real focus on weight management as well. So if we take both of those in practical terms for our job and clinician, where and when is there a role for GLP-1? I think that would be a really interesting sort of discussion to have, and quite a nice take home as well.
Yeah, you know me, Amrit, I tend to be very practical and pragmatic in these situations. So, I know some people in some areas will be completely restricted by NICE guidance and local prescribing restrictions. For me, it's about looking at that person in front of me. If I tend, for most of my patients now, I have metformin SGLT2 inhibitor for the great majority of my patients. Where do we go next? So if I have got somebody in front of me who is really struggling with obesity, particularly, plus or minus has existing atherosclerotic cardiovascular disease, I really strongly feel that for that person, the next best medication on the basis of evidence that we have and the weight-lowering benefits of GLP-1s will benefit from a GLP-1. So in that group, where I really feel that is going to be the best next option, and actually often in those groups, say you're going to go for a DPP-4 inhibitor or a sulfonylurea, perhaps, third line otherwise, often you'll end up then quite quickly moving to the GLP-1 in my experience. So actually, I have to admit, I do go beyond NICE and move towards ADA, EASD in that situation. And in patients who I feel will benefit the most, I absolutely will go metformin, SGLT2, and then GLP-1 third line. And that can be really effective. You've got, somebody in their 50s, type 2 diabetes for a few years, struggling with a BMI 35, 40. The benefits I've seen in my own clinical experience of going for a GLP-1 next are significant in terms of glycemic control and weight lowering. And that can have an impact well beyond their type 2 diabetes, both metabolically and beyond, looking at, musculoskeletal issues, looking at quality of life, mental health even. And so I tend to take a pragmatic approach. And if I think that person will particularly benefit from a GLP-1, I'll tend to go that little bit earlier than NICE are currently recommending. And of course, we can quote the ADA EASD guidance, or consensus statement rather, perhaps to support our prescribing decisions if that's necessary to do so.
Brilliant. Okay, moving on, switching it up a little bit, looking at glucose monitoring. Amar, I know you wanted to just bring us up to speed about some NICE updates regarding glucose monitoring.
Yeah, because I guess this is something that has certainly been in the realms of type 1 diabetes care for many years now, and certainly pushed by a lot of people across the world, and certainly in the UK by a number of people that we know, that really, this is something that's for the people. In a way, it's something that really changes and helps support people with diabetes in their management and checking blood sugars. You can imagine checking your blood sugars 10 times a day and sticking a needle in your fingers, how annoying that might be at times. Some people might like it, some people wouldn't do it all the time. So this is where continuous glucose monitors come in, because they avoid that, and they provide a regular kind of stream of data effectively and blood sugar monitoring. So there's continuous glucose monitoring, real-time continuous glucose monitoring, and intermittently scanned continuous glucose monitoring, or the flash glucose system that we know well. And the guidelines are really updated. So the type 1 guidelines were updated, but so were the type 2. And basically the type 1 guidelines have really made it clear that for anyone with type 1 diabetes in the UK, England, let's say, that if they have type 1 diabetes, they should be offered a continuous glucose monitor, either one, as first line. This is the mainstay of their management, of their glucose monitoring, should be a continuous glucose monitoring device. And if they didn't want that, then you look at the alternatives of blood glucose monitor. And this really means that basically anyone with type 1 diabetes should really get a continuous glucose monitoring device, which is probably one of the first countries in the world to kind of have this universally for everyone with type 1 diabetes. And it's great to see that, from an England perspective, that we're leading the way in technology. And that really is probably more in the realms of initially, at least in secondary care, but again, a lot of primary care, again, because, again, the regular prescriptions and being aware that this is the new change, that there's no kind of RMOC criteria or anything. It's all type 1 diabetes, that's it. They can have a continuous glucose monitor. And that's fine. But then it's actually because what was not quite surprising but interesting is what it progressed to those with type 2 diabetes as well. And so there was an update to the type 2 diabetes guideline with regards to glucose monitoring, and specifically continuous glucose monitoring. And actually, people with type 2 diabetes can be offered a continuous glucose monitor. So they say, for example, if you're looking at the guideline directly, offer intermittently scanned continuous glucose monitoring or the flash system for those with type 2 diabetes on multiple daily insulin injections, so multiple, so more than one essentially, who have recurrent or severe hypoglycemia or impaired hypoglycemia awareness, or a conditional disability such as learning disability or cognitive impairment. That means they can't monitor their own blood sugars, or if they were monitoring more than 8 times a day for clinical reasons. So again, that opens up to kind of almost those with type 1 diabetes, why we would want them to have continuous glucose monitoring in the past, and now move it to those with type 2 diabetes. Or again, if you need third-party monitoring of your blood sugars as well, they say. The interesting thing, I guess, with that is this is where it perhaps impacts a broader range of healthcare professionals, not just myself or in secondary care, but also those in primary care, because potentially you'll get a lot more people aware of this. Now, what I've found locally is that whilst nationally there's this guideline for saying that, the practicalities of that and the reality of that is we're kind of almost a year in from that change, maybe not quite, 8 months or so. And the uptake of that in those with type 2 diabetes is perhaps not as clear as those with type 1. I mean, I think probably for good reason, we're trying to get those with type 1 to ensure they have that, but also those with type 2 only in certain situations, and also still waiting for the local prescribing committees and medicines management teams to kind of get on board with this change, because again, it's quite a big impact. If you imagine even just 5% of people with type 2 diabetes, if they were to be offered it, significant cost to the system. Again, you guys are the people in primary care so interested.
Exactly. No, I was going to say, how has that played out in primary care? I mean, Patrick, if we come to you first.
So I suppose there's a lot of our colleagues are quite concerned about this. I think, whilst I see this technology really useful in terms of giving people the data so they can either adjust their lifestyle or they can adjust their insulin. And of course, there's a lot of older people with type 2 diabetes who are on insulin who perhaps don't do either. So and require more input from because of more of a paternalistic approach to healthcare, that they expect their healthcare professional to manage their diabetes rather than them manage themselves. And I think so that's a challenge in terms of workforce, because we're short of them, if you haven't noticed, workforce at the moment. So I think it's a challenge, but I think within that group, clearly there's good value. And actually, they NICE looked at this, and of course the cost per quality, these quality added life years, the incremental costs are really good. I mean, they're much better actually than the SGLT2 inhibitors. So we should be prioritizing this. And it's certainly in my area, we are trying to do this. As we speak, we are trying to get the finance people to sign it off, but it is challenging, and we will see if we're successful. But I think at the heart of it is the health inequity which we see in type 2 diabetes, that we certainly we need to be helping people who are living with that health inequity to live better lives and age better.
Sarah, what are your thoughts? Well, perhaps your thoughts about it, and then what is the reality where you're working as well?
So my thoughts are, this is coming. I suspect in 10 years' time, we'll say, gosh, do you remember when everyone was finger prick testing? Do you remember when we used to make people, stab their fingers however many times a day? Yeah. Amar says 5 years. I think probably 10 realistically. But I honestly think it's coming. So we have to find a way for this to come into our everyday practice. And there are concerns about that in primary care, concerns that it's beyond us, perhaps, that it's seen as a specialty area. Do we need funding for this? What should the pathway look like? Who owns the data? Lots of little hurdles that need to be overcome. And I think that's being worked through in lots and lots of areas at the moment. I see this technology as just a simple alternative to capillary blood glucose testing. It definitely enhances self-management of people's diabetes. And then, if you want to get stuck in and have a little look at those readings and make those changes, just like you would look at someone's capillary blood glucose readings, then fantastic. In terms of my experience at the moment, there's challenges, lots of concerns from colleagues, lots of little hurdles that need to be overcome. But I think we'll get there. And I think what will happen actually is that this will slowly seep in. And then we'll get a bit of herd mentality, and people will get more used to the idea and more comfortable and clinically confident with this sort of technology. And then we'll find actually, eventually, it becomes the norm. But I absolutely echo Patrick. Of course, it's often the people who shout loudest who get these things first. And we need to be aware that actually some of the patients that will benefit the most are the ones who will not shout at all. And we need to be aware of that. And I try and identify those patients. I think we've got an important role there.
And just just going back to type 1 diabetes, I think primary care has a huge role in signposting or even initiating the technology in type 1. They do require some support and education so they can effectively use this technology. But I was told by someone it's all the data comes from, you improve your glucose control by time in range simply by the number of tests you do. And it's as Amar has said, it's painless now to test, thousands of times a day if you really want to, which you would never do with blood glucose testing.
Brilliant. Thanks for your thoughts. I mean, it's definitely, it's no longer the future, it's the present now, isn't it? But it's just going to rapidly evolve, it seems, and involving more patients than ever before. Okay, so we're on to our final update now. And this is an area that I know Patrick has a particular interest in, kidney disease in diabetes. And so we've got an update from KDIGO, the International Kidney Group. So Patrick, over to you for the final update of this first video.
Yeah, well, I'll try to keep this one shorter because it's, again, so KDIGO is this international group of trialists, really, who come together to give us advice, and they've given specific advice about CKD in diabetes, and it was updated last year, so 2022. And just like the ADA, it's all about those infographics, and I'm sure that technology will show these wonderful infographics. I particularly like the pyramid because it gives this sort of, it nicely highlights for CKD. Remember, CKD is as prevalent as diabetes, about 4% of the population. So we've got in the UK. So you have this foundation of lifestyle, and then you go on to, standard therapies you would add in. That's metformin, SGLT2 inhibitor. If they've got hypertension, a RAS blockade, and a statin. For all, remember, most people with CKD die of cardiovascular disease before they ever die of a kidney problem, probably by a ratio of 4 or 5 to 1. And then if glucose isn't controlled, what do they suggest? A GLP-1. If they have got established cardiovascular disease, of course, you're going to give them antiplatelets. And if they've got type 2 diabetes and you cannot control their albuminuria despite giving a RAS blockade and an SGLT2 inhibitor, this is the sort of new bit. They're talking about we need to add in a non-steroidal MRA, finerenone, in other words. So now that's not quite actually as the evidence would suggest it sits, but I see the rationale. It has a different mechanism of action. I think we have covered that again in other subjects. And then, of course, we've got to manage all their risk factors, so lipids, glycemia, and blood pressure, in addition to all that's been said. And that's beautifully laid out in that little pyramid. There's for those people who like flow charts, there's one of those as well. Of course, it's a position statement. So this is ideal clinical care, I think, based on expert advice. It hasn't gone through the lens of cost effectiveness. So that's a criticism, I think, which is fair. But quite honestly, I find it really helpful. And it's a nice, simple message. These images, for me, what is it? A picture paints 1,000 words. This is what it does. So in terms of the implication, Sarah knows a thing or two about CKD, so I'll pass that over to Sarah, really, in how she feels. I think we've covered a lot of this already, I suppose, but if we focus perhaps on the role of GLP-1, where as a third-line agent for CKD, and this role for non-steroidal MRA for when albuminuria is not appropriately controlled, and perhaps why it's important to control albuminuria.
That was a lot of questions, Patrick. But essentially, I think sometimes, particularly in primary care, managing CKD, particularly in the setting of diabetes, can feel really overwhelming and a little bit out of our depth. There's an awful lot to think about. And what I like about this guidance is it brings position statement, rather, it brings it together a little bit. It makes it a little bit simpler, certainly, for the likes of me, where I like to see something, okay, what am I meant to do next for this person? And actually it makes it really quite simple. And it's exciting to see developments. It's exciting to see Finero, I can never say it. It's one of these ones I just cannot say. Non-steroidal antagonists, yeah, those ones. Lovely to see them come out and exciting. But actually, I think the guidance is a good reminder that we've got to get the basics right in diabetic kidney disease. So getting everyone on maximum dose ACE or ARB, and I know there's a lot of patients out there that are not on that, and it's a good reminder that we need to go there first of all. And the pyramid is good because everyone has to be on this, and then we consider that in some groups and so on. And prioritizing our SGLT2s, of course, in our patients with kidney disease. And then GLP-1s, and that's probably quite new to a lot of people. That thought, actually, we don't always think GLP-1s kidney disease because they haven't got that breadth of evidence that we see from the SGLT2s. But actually, it's important to remember, and it's a good reminder, that in fact, we know that many people with kidney disease, exactly as Patrick says, are a massively high cardiovascular risk. So prioritizing medication that reduces that risk is really important in that group. And remembering our cardiovascular risk factor control as well. So that blood pressure control, that lipid control, that healthy lifestyle as well. And, great to have finerenone as an option next, fantastic. Is that happening in real life clinical practice yet? No. We wait nice technology appraisals still, and then we'll wait for local pathway development and so on and so forth. I suspect initially, like many new treatments, that will probably sit as a specialist initiated medication, first of all, with patients who we do get advice from guidance or indeed refer to our renal colleagues, rather than necessarily sitting in primary care initially. But time will tell. Great to see these options coming forward for our patients living with kidney disease and diabetes, though. Amazing.
Yeah. Especially after so many years of very little in this field. As you say, great to see that. Patrick was asking about albuminuria. Amar, any kind of thoughts on that from your side? The importance of measuring albuminuria, because this is something that we all know has dropped off since measuring urine ACR in diabetes came off the QOF targets, isn't it? It's come down quite significantly, the uptake and measurement of urine ACR, but still critical, isn't it?
Absolutely. I mean, if you could say there'd be something you could check that you would highlight before significant damage occurs to your kidneys and your risk of kidney disease, chronic kidney disease and dialysis, something you could do to kind of identify that, to prevent that or reduce the risk of that. Why wouldn't you want that, really, to be honest? And this is what the urine ACR is. It's an early predictor of not just a predictor, but also a monitoring tool to someone's kidney disease. So I found it interesting that there's a nice study done a few years ago looking at people who had raised urine ACR with diabetes, then raised urine ACR and reduced GFR in the setting of diabetes as well. And they found that your mortality risk increases the more you add to that. So if you have type 2 diabetes, yet you have a slightly higher mortality risk than if you didn't have type 2 diabetes. You add in a raised urine ACR, that increases the mortality further. Add in a raised urine ACR and a lower EGFR, then that increases the mortality further. But if you flip it around and say, well, actually, if you can get someone from a raised urine ACR or before they've hit the GFR and deterioration, you can actually reduce the urine ACR before it affects the GFR, so you reduce the mortality. And if you can get rid of that high urine ACR, you can reduce the mortality further. And also all the dialysis, etc. So yeah, as a tool, as a marker, I think it's probably one of the most important things, probably the most important things in chronic kidney disease management, isn't it, in type 2 diabetes? And something that we should all be doing, primary and secondary care, regardless, it's not one person's responsibility. And it's about highlighting and doing it, then and there as a spot sample, not just an early morning sample, just getting it done, because that will quantify kind of a risk in a way.
Yeah, absolutely. And really important, actually, as part of some of the new licenses that we're seeing for renal medications that are coming out, whether the patient does or doesn't have albuminuria may actually ultimately result in whether the medication is indicated or not. But more on that, I'm sure, in other videos. I think we'll draw things to a close there. Obviously, you could tell how excited we were. We were only planning to have a short video this time, but we've gone way beyond how many minutes we were planning to record for. But that's because 2022 really was yet another jam-packed year. We've only touched on a few specific areas, But in particular, we focused on guideline updates, international advice that has been updated as well. And we really hope that you've enjoyed this video and perhaps picked up a few tips that you may be able to implement into clinical practice. So if you'd like to comment, please do comment on this video. If you'd like to send us a message via Twitter, please do that. Reach out to us across the social media platforms. It's been a great pleasure to speak to everyone today. Sarah, Amar, Patrick, thank you all for your input and your thoughts today. But that's all from us today. Do stay tuned, though. We've got more videos coming up in this 2022 review series, and we look forward to seeing you soon. Take care, everyone. Bye-bye.